Tonight, I am very excited to introduce Dr. Adam Ratner in celebration of his book, Booster Shots, The Urgent Lessons of Measles and the Uncertain Future of Children's Health. Using a combination of patient narrative, historical analysis, and scientific research, Dr. Ratner, pediatrician and infectious disease specialist, argues that the reawakening of measles and the subsequent coronavirus pandemic are bellwethers of a forgotten knowledge, indicators of decaying trust in science, and an underfunded public health infrastructure. Dr. Ratner details how solving these problems requires the use of literal and figurative booster shots to gather new knowledge and retain the crucial lessons of the past. Adam Ratner is a professor of pediatrics and microbiology at NYU Grossman School of Medicine and the director of the Division of Pediatric Infectious Disease at Hasenfeld Children's Hospital and Bellevue Hospital Center. In addition to practicing medicine, Dr. Ratner directs an active research group and teaches students, residents, and other trainees. He speaks widely in both academic settings and news outlets on topics relevant to vaccination and infections in childhood. His work has appeared in the New England Journal of Medicine, PNAS, Pediatrics, and other venues. He edits a major textbook of pediatric infectious diseases, has chaired grant review panels for the NIH, and serves on numerous advisory and editorial boards. He is speaking on a personal capacity this evening. Dr. Ratner will be in conversation with Dan Diamond. Diamond is a White House reporter for The Washington Post. He was previously a national health reporter covering politics, policy, and public health. He joined the Post in 2021 after covering the Trump administration for Politico, where he won a George Polk Award for investigating political interference in the pandemic response. His investigations into a range of topics, including Trump officials' use of taxpayer-funded charter jets, not-for-profit hospital spending, and how Congress stripped Pacific Islanders of their health coverage, have also been honored with several journalism awards. Without further ado, please join me in welcoming to Politics and Prose Dr. Adam Ratner and Dan Diamond.
Hello. Having come to a book event here recently, moderating your voice on this is very important, was my takeaway. Well, welcome. I am a White House reporter at The Washington Post, but until recently, I was a health reporter covering the rise of Robert F. Kennedy Jr. and the evolution of the anti-vaccine movement. So I can't say that I'm delighted to talk about a highly infectious disease, but this topic is hugely important and very much in the news. So I'm pleased to be with Dr. Ratner to talk about this incredible book, Booster Shots. And we'll speak for about half an hour before opening it up to Q&A. I thought first we could start, Dr. Ratner, with this, how this came to be. You are a New York City physician. This is your first book. How does a New York doctor write his first book?
So there was a measles outbreak in New York City in 2018 and 2019. And at that point, I had been practicing pediatrics and pediatric infectious diseases for quite some time. I had seen a lot of stuff, but this was new. And that outbreak really changed the way that I thought about my job and my patients and health policy in general. So what happened was that in a city with about a 98% vaccine coverage rate with the measles, mumps, rubella vaccine, so a very, very good rate of coverage. We usually want more than 95% to prevent an outbreak. So citywide, we had about 98% coverage, and yet we were seeing day after day after day multiple cases of measles coming into our hospital. Some children who were very, very sick. Some kids who needed our highest level of care in the intensive care unit. And they were all from specific clustered communities in Brooklyn. And what came to be known was that these particular communities had much lower vaccination rates, more like 70 or 80%, which is much too low. The outbreak was seeded by international travel. Someone who was unvaccinated went abroad, caught measles, and came back. And it's, first of all, I think it changed the way I think about our need to do surveillance for disease and our need to be much more granular in terms of looking at specific communities. And then the second thing was that I had thought up to that point about the anti-vaccine movement being sort of a fringe thing, sort of a, concentrated in a few communities, not really something that was an issue in New York. And it turns out it was very much an issue in New York City. And this was interesting to me from a policy point of view. It was interesting to me from a medical point of view because this was a disease that I had really never encountered before, and then all of a sudden was having to deal with. And it seemed like a look into the future. It seemed like with the growth of the anti-vaccine movement, and with the fervor that I was hearing from these parents of the patients who came in with measles about not wanting to vaccinate their kids, I was nervous that this was going to be something that was going to take off. This was all pre-COVID. And once that outbreak died down, I thought to myself, this is a story that's important to tell. And I started putting together the idea of writing a book about measles. And then COVID happened, and it once again changed how I thought about all of those things and really coalesced the story that I wanted to tell.
So just going through your process, you have a story that you want to tell. You think it's a warning of what is coming, and COVID shows that it's a warning. How do you go about writing that book?
So it turns out that you can just Google how to write a nonfiction book proposal. And so that's what I did.
That's actually the secret behind most of the books in this room. Yeah.
So honest to God, I've always loved writing. I had no idea how to write a book or get a book published, and so I didn't know if you had to write the whole book and then send it, or so I literally Googled how do you do this, and somewhere found a basic outline of a nonfiction book proposal, wrote that, sent it to a bunch of agents, got no response whatsoever. I was like, is this thing on? And then finally, I had the good fortune to have a colleague at NYU who is a historian who writes about medical things. And I went to him and I said, how do I do this? And he said, oh, I've never had an agent. I've never, I just have, the same editor I've always had. So I talked to that person who said, you really need an agent. And I said, well, that would be great if they would email me back. So I eventually got a name and beat the bushes a little more and had a wonderful agent who helped me actually write a real proposal.
I enjoy your writing. I find it very graceful, especially for a first-time author.
Thank you.
In part because you give measles a kind of persona. You anthropomorphize it. And I made some notes. At one point you write, quote, measles is a bully. It has always picked on the weak, the undernourished, and the crowded. At another point, you put it like this: measles not only loves a crowd, it needs a crowd. It never could have successfully spilled over into humans without one. How did you decide to do that, to give measles kind of a personality?
So the thing that really leapt out to me about the measles story is, it's something that we humans have had experience with for centuries. And when you look back, whether it's, one century at the early 1900s New York City in the tenements where you see enormous death rates from measles and from other infections, just half a mile from where you have the richest people in the city living, where measles is just a rite of passage in childhood, to a century before that, where you have colonialism and and the British island of Fiji in the late 1800s, where because of Fiji joining the British Empire, there was increased ship traffic. Measles came there when it hadn't been there in many, many years and killed a quarter of the population over the course of 2 weeks. And that is the combination of colonialism and economic oppression and malnutrition all together to even before that. Like, that story keeps being told. And
Measles exploits the weaknesses.
yeah,
among us.
that's exactly it. It's a probe for the weaknesses. And, I'm a pediatrician, and so I think about kids, and so it struck me as a bully.
If you saw measles in a bar, would you pick a fight with measles?
Is it right to pick a fight with a bully? I don't know if that's the right move. Maybe it is.
I mean, in America 2025, who knows what goes?
Yes, fair enough.
So you in this book go through the history of measles. You taught me a lot of things as a health reporter that I did not know before, that there had been an inoculation attempt 300 years ago almost with measles. When you think about the efforts to learn and combat measles over time, was there a breakthrough that could have happened that was missed in our course of humans in this disease?
So yes, but I think it's probably a later breakthrough than I would have thought initially. So the technical breakthrough that allowed us to control measles was exactly the same technical breakthrough that allowed us to control polio. And it was made by the same guy. So John Enders was a professor at Harvard, and he figured out how to grow human cells in dishes, and other animal cells as well, in dishes in the lab in a way that allowed them to support viral replication. So what that essentially let him do was grow vast amounts of poliovirus that you could then kill and turn into a vaccine. Once that was done, after the Salk trials of polio vaccine, and after that vaccine was successful and he had won a Nobel Prize, he went back to the thing that he was interested in the first place, which was measles. And he asked, can we do the same thing with measles? And so he was really the linchpin in figuring out how we could make a vaccine that would let us control measles. And so that was the technical breakthrough, but that one wasn't missed. That one was exploited. I think what we missed came after that, and it was a policy issue, which is that when the polio vaccine came out, there was, and some of you may remember this, there was tremendous excitement. Like, people were enormously excited that there was a polio vaccine, that there was the potential to prevent this horrific disease. And the only question, it wasn't, should we give this vaccine to our kids? It's how fast can we immunize every child in the country? And there was federal funding, and there was funding from the March of Dimes, and people made it happen. And that didn't happen with measles. What happened with measles was they had a rollout of the vaccine was licensed in 1963. There were actually two vaccines licensed at the same time, a killed one like the Salk vaccine and a live attenuated one, which is like the Sabin vaccine. The live attenuated one worked much better and was the one that was, that the Surgeon General said was preferred, but the other one had much less in the way of side effects. And so there was this confusing message for parents where there are two vaccines, but we want you to get the one with more side effects. And there was no federal funding. They were like, oh, just go to your doctor, which meant that parents had to bring their kids to their doctor for an extra visit. They had to pay $10 out of pocket, which is like $100 today, for each dose of this vaccine. And unsurprisingly, it didn't go well. And that was an enormous missed opportunity. And I think it set us back decades in terms of controlling measles.
I thought that was so interesting in your book, the contrast of the polio vaccine and the measles vaccine, one that is hailed, one that has immediate effect, and then the fight against measles continues for decades and decades. Really, it's not until 2000 when we are seeing mass eradication, or eradication might not even be the right word.
Right. So to be a little semantic, maybe a little pedantic.
It's your book. Be as pedantic as you like.
Elimination and eradication are different. Eradication is what we did to smallpox. So that means there is no smallpox circulating anywhere in the world. We don't vaccinate kids against smallpox anymore. My wife and I, who were born a few months apart, one of us has a smallpox vaccine and one of us does not. So there was like a switch at the point where smallpox was controlled that let us do that. And that's what eradication lets you do. Elimination is great. It's a huge achievement. But what it means is no ongoing spread of a disease in a particular geographic area for some period of time. And so in 2000, we did an amazing thing, which is that we eliminated measles from the United States. So there was no ongoing circulation of measles in the US for more than a year. Awesome, but you still need to vaccinate people. You still need to do surveillance. It doesn't mean no cases of measles, because there will always be people traveling to other places where they may get it and bring it back. So it's a state that requires constant vigilance.
How contagious is measles?
It is bonkers contagious. That is
the technical term.
That is a pediatric term. Measles is the most contagious disease we know. It is more contagious than flu, more contagious than polio, more contagious than Ebola or anything else you can think of. If someone with measles walks into a room of people who aren't immune to it, about 90% of those people will get the disease, and it spreads extremely efficiently. So it is easy for it to pass through a crack.
So there are dozens of people in this room. If one person has measles, how many people would have measles?
How many of us are vaccinated?
Well, that's actually my next question. My understanding is that vaccination protection can decrease over time. So if you were vaccinated 40, 50, 60 years ago, how worried should you be about the resurgent measles outbreaks?
So I think there's a little bit of cause for worry, but not a ton. I think that measles immunity can wane, but not nearly as much as some other things. So there's the MMR vaccine is measles, mumps, and rubella. And we see mumps outbreaks in highly vaccinated populations because immunity wanes over time. You can see that with measles, but it's rare. So people who've had 2 doses of measles vaccine, which is what's recommended now, about 97% of them have long-lasting protection. And, I can't say that it's lifelong, but it's pretty good. So the recommendation somewhere like West Texas now that has a measles outbreak going on is not to revaccinate people who've had 2 doses. It's to make sure we get everyone to that 2 doses.
It takes about 2 weeks for the measles rash to appear. In a world where physicians may not have seen measles much before, do we need more awareness and training for doctors, for the public, of the somewhat early signs, I read in the book, the Koplik spots inside the cheek? Like, do we need more awareness of what measles might look like so we're not getting to 2 weeks without knowing?
Yeah, this is something we're talking about a lot in pediatrics now. And it was this bit us a little bit early in the 2018 measles outbreak. We were lucky at my institution that a resident physician who had actually never seen a child with measles diagnosed the first kid and put them into an isolation room early, which helped with not having more spread, but you can't rely on luck like that. There are a bunch of us talking about how to put out information about how to diagnose not just measles, but other vaccine preventable diseases, because you have a whole generation or even 2 generations of pediatricians who may not have seen these things. It's a problem.
In your book, you travel through history. You talk about some physicians who were notable, some episodes of measles outbreaks. I'd like to talk about a few of them. One is the Danish physician, and I apologize if I'm mispronouncing his name, but Peter Panum. I did watch a video from Denmark just to make sure, but it struck me that you admire him, at least when I'm reading between the lines of what you wrote. Can you talk a little bit about Dr. Panum and what he did that was so significant?
Yeah, so this is a story that I did not know well before doing the research for this book, but I found fascinating. And it's from the 1840s. In 1846, these islands, the Faroe Islands, which are north of Scotland, quite isolated were Danish colonies, and they were really under complete economic and political control of Denmark. So there was one ship route that came to and from the islands. So the only way in or out in terms of commerce was from Torshavn to Copenhagen, that ship route. And the islands were isolated physically, they were isolated politically, they were isolated economically. And they had gone 65 or so years without having a case of measles. So basically, the entire population was susceptible to measles. And a man who lived in the islands went to Copenhagen, was exposed to someone with measles, came back on a ship, and that one person seeded an outbreak that went on for months and that killed a huge percentage, like thousands of people in the islands. And at some point early in the outbreak, the Faroese physicians realized that they were in over their heads, and they asked for help from the Danish government. And the Danish government, a backhanded insult, maybe, sent 2 medical students. At least they sent 2. So and one of them was this guy, Peter Panum, who, I mean, in fairness, had just graduated from medical school, but still was not a highly trained person. And what they did was they went throughout the islands. They prescribed the medical care that they could, which was pretty limited at the time. They tended to the sick, and there were a lot of very sick people who got sick all at once. So that can be devastating to a population. It wasn't just the kids getting sick. It was, people of all ages. And the thing that Panum did, which was unlike what other physicians tended to do, was he was very systematic. He went from village to village. He interviewed people. He wrote down when they were exposed, to whom they were exposed, how long, what the length of time was before they developed a rash. He found a place where one group of men went out on a boat to do some fishing together and then came back, and that seeded a big outbreak in one of the villages. And he got the dates for that, and he drew a map and figured out like really basic epidemiological characteristics of measles that had not been known before. There was a lot of confusion because if you tried to do that in Paris or in Copenhagen or something like that, you had so many people with measles all the time that you couldn't trace those routes of contagion. And so he, using essentially a calendar, a map, and a pen, figured out these basic properties of measles. And I saw parallels between that and what all of us who were physicians were doing early in COVID, where we were dealing with a new virus that we had lots of fancy machines and stuff, but we didn't really know how it was transmitted. We didn't really know the scope of the illness or how quickly people would recover, and we were talking to our colleagues and writing things down.
And making your own Panum map. The parallels in history of Peter Panum is doing this in the 1840s. You have other chapters of measles outbreaks and physicians attempting to solve them, and then your own experience in New York City in 2018. Yeah. What was most shocking to you as you're talking to the parents of kids with measles and kids who are unvaccinated, I assume? Was there some conversation that lingered with you, some lesson that you feel like you took from that experience?
Yeah, I learned a tremendous amount in a very short time during that outbreak. And I think the thing that was initially most shocking to me was the difference in my discussions with the parents and the grandparents of the children who had been hospitalized, because the grandparents were people who had vaccinated their kids, and many of whom remember, even if they didn't remember polio directly, knew people who had been affected by polio. These were people who believed in vaccines. And then the parents of the hospitalized children, almost without exception, were people who had opted not to vaccinate their kids. And it was the disconnect between that generation that was, I think, the most, at least initially, shocking thing that I saw.
the outbreak in New York centered around the Orthodox Jewish community. There was an outbreak of measles centered around Disneyland about a decade ago, and wealthy communities in California. What do these communities have in common?
So it's hard to put a fine point on it. I mean, I think what they have in common is sort of a shared mode of thought and a shared having been targeted by an anti-vaccine movement. I mean, what happened in Brooklyn, I think, was really interesting because these communities are not ones that are getting their health information from Facebook or Twitter or anything like that. They, for the most part, are not on the internet. These are places where there are things like conference calls among young mothers in the community to talk about all sorts of things with parenting. And there were anti-vaccine folks who were invited to those conference calls. There were laminated brochures that were printed up and left in supermarkets and left at people's doors, and those were printed in both English and Yiddish, with anti-vaccine messages. This was a sophisticated attack on that community. In contrast, I think with the Disneyland outbreak, it was the same thing. There were clustering of very low vaccination rates. It tended to be wealthier groups. It tended to be people who did find their information from Facebook or Twitter, but where they had been sucked into these small communities on those social media networks and were targeted that way.
You write about the parental groups and some of the other groups that have organized around vaccines and raising questions about them. There's a character who pops up several times, Robert F. Kennedy Jr.
Never heard of him.
You may be among the few at this point, but Robert F. Kennedy Jr., the scion of the famous Democratic family. What is your impression, having done no research on RFK Jr.'s role? Is he says he's not anti-vaccine? Is that true?
No. I can do a little more. So, I mean, first of all, this book was written before the most recent election. It was certainly written before RFK Jr.'s appointment as HHS secretary.
So he is in charge, just to be clear. He is now in charge of all the health agencies in America, including the ones that oversee vaccine approval and supply.
Yeah. And this is extremely alarming because he has spent much of his adult life fighting against vaccines and fighting to tear down trust in vaccines and to undermine the infrastructure that approves and keeps safe our vaccine supply. And I think that part of the issue is there have been a lot of fits and starts to really having a robust vaccine infrastructure in the United States. And there are policy decisions that have been made, things that have been done to ensure that we have that we have school mandates that are robust, things that ensure that we have surveillance systems that work well, where we can detect even rare vaccine adverse effects. And I think that all of that is at risk, and we're seeing that now. I mean, just to go policy for 1 second, the CDC Advisory Committee, the Advisory Committee on Immunization Practices, which meets 3 times a year, was supposed to have a meeting this coming week. It's important. We were talking about many vaccines that are under consideration, safety data, efficacy data, and that is all being postponed because that meeting has been put on, as far as I know, indefinite hold.
Somewhere in the audience, there is a New York Times reporter named Cheryl Gay. Oh, there she is. Cheryl Gay Stolberg, who has written quite vividly about some of the risks to Americans' vaccine infrastructure. Also, I may be carrying this conversation for the next 20 seconds, but.
Sorry. Okay. You okay? Okay. Sorry, I'm back.
No, this is a doctor at work. We're talking a bit about RFK Jr. And one thing in the book that I did not know, I had not realized, John F. Kennedy Jr. as president helped expand the federal role in vaccination.
Oh, John F. Kennedy, not Jr.
Oh, sorry. Yeah, John F. Kennedy. No, wait. JFK. Yes, JFK Sr. That's right. RFK Jr., 60 years later, is now atop the health agencies and one of America's most famous vaccine skeptics. What do you think about the symbolism of that we've gone from the polar extremes?
Yeah, it is astounding. I mean, I didn't know much of this when I started writing, but we owe a debt of gratitude to Kennedy and to Johnson, I suppose, unsurprisingly, for putting in place a lot of the infrastructure that funds vaccines today. The thing that the combination of stable federal funding that really started in the 60s, and then the thing that really moved the needle also was the Vaccines for Children program, which was in the Clinton administration. But yeah, I think there is important symbolism there, and I think JFK felt strongly, positively about vaccines.
Well, to stay on politics for a moment, we are in Washington, D.C. If you go out that door behind this audience and drive down Connecticut Avenue about 25 minutes, you'll be at the White House, where President Donald Trump sits, and he has raised questions about vaccines. You keep going further, you'll hit the Humphrey Building, where RFK Jr. now has his office. If you had 5 minutes with one of these leaders, what would you tell them? Maybe they're in the store right now. I don't know.
It could be. I think the thing that I would say is that we are at a very different place in terms of child mortality now than we were a century ago. Kids do not die at the same levels that they did a century ago, and that is in large part due to vaccines. If you look at the graveyards of a century ago or the family histories of a century ago, you have children dying of diphtheria, of polio, of measles, of all of these things that we can now prevent. There are so many things that are still dangerous in childhood. So many, you can't vaccinate against a car accident. You can't vaccinate against a drowning. We can vaccinate against those things. And so it is so important that we do that because none of that progress is guaranteed.
It strikes me that the folks that you might know in New York City or the folks who are here at this Washington, D.C. bookstore are almost an easy target for that message. It's the people who are in isolated communities or communities that get a very different information stream. How do you see, as a physician, the challenge and the possibility of reaching people in parts of the country that don't want to hear this message? What is the solution?
I don't think there's one solution, but I will tell you the approach that I take because I come at this as a pediatrician. And I think that even now, even in this horribly polarized time, I think that most parents still have trust in their pediatricians. I hope that that's true. And anti-vaccine parents and parents who question vaccines are not parents who don't love their kids. Like, these are people who love their kids and they want exactly what I want or what their pediatrician wants for those kids, which is for the kids to grow up happy and healthy. And I think you have to start there. Like, I think that is the moment of connection. And then there are the details, and the details are important, like how you get there. But I think it's hard. It is hard to fight against the disinformation that is out there. It's the anti-vaccine messages are seductive and they are pervasive. And it's, it is when you think about the autism message that is out there from the anti-vaccine folks, it is such a simple and clear message. Vaccines cause autism. It's 3 words. It's easy to remember. It's 100% wrong. But that almost doesn't matter. And if you ask, if a parent goes and asks a pediatrician, well, then what does cause autism? A good pediatrician will say, it's complicated. There are genetic causes of autism. There are infectious causes of autism. There are cases of autism that we do not understand at all. It's a much more nuanced message, and that's harder to get across.
Secretary Kennedy and his allies say, we need more information about vaccines. We need to understand what the causes of autism might be. Do you see any value in conducting further vaccine studies or changing the vaccine schedule that young children receive?
So we are constantly doing further vaccine studies. So there are robust surveillance systems in the United States looking for vaccine adverse events. And if you look at what happened during COVID, which I think people see very differently in retrospect than at the time, the COVID vaccines are a triumph. They were available in under a year for a deadly pandemic. They have saved tens of millions of lives. And when there were rare and true adverse effects, and so I'm thinking of, rare myocarditis with the mRNA vaccines, rare blood clots with the adenovirus vectored vaccine, the Johnson & Johnson vaccine, those were picked up by surveillance systems. Like, that's an example of the system working. And we do that with all of them. And some of the surveillance systems are designed to be very sensitive, like they will pick up small signals, but they're not always accurate. And then some of them are designed to ask much more focused, accurate questions. And those systems have to be used in the way that they're designed, and they have to be used together. But the idea that no one has been looking at vaccine safety is insane. And if you look at if you go back and you watch the ACIP meetings or the FDA advisory panel, the VRBPAC meetings,
The committees that are recommending vaccines.
Right. You might die of boredom watching these things, but they're like, the people who are talking, the people who are presenting the data care deeply about this. And what they're trying to do is make sure that things that we're recommending to the population, to healthy children, like, we have a very low threshold for what is acceptable in terms of side effects.
I'd like to move to questions in a moment, and there's a microphone over close to Dr. Ratner on this side. But I have a question or two if folks want to start queuing up now. This would be a good time to do it. In the book, Doctor, you write about being the target of protests. I believe you were going into a conference to talk about vaccine preventable diseases, and there was some sign with your name on it, and you write, it said, "You do not belong in the Jewish community." What does it feel like to be targeted by protests over vaccines?
It's a mixed bag. Like this much of me was a little proud, I have to tell you, but it's like, look, kind of made it. No, it was sad. Like, I think that most of us who are in pediatrics are here because we want kids to be healthy and be safe. And, we spend a lot of time talking to parents about balancing risks and benefits and, anticipating what may be coming next in their kid's life and how they can best stay safe. And it's not an area where there are a lot of protests usually. And this was said because it was a conference in the Orthodox Jewish community that I was speaking at that was about vaccine preventable diseases. And it was basically to do what you were talking about before, which is that I went through a bunch of vaccine preventable diseases, showed pictures of things, taught pediatricians how to recognize those things. This is not controversial, or it shouldn't be controversial. And, there were a handful of protesters. People have had to deal with much, much worse than I did, but it made me sad.
Well, I guess we'll see how many protesters are queuing up at the microphone. Let's go to this gentleman here.
Great.
So 2 questions. One is personal and one is about access to vaccines. Personal one is, I was born way before 1963. So assuming I had the measles as a child, is my immune system stronger than a vaccine that I might get tomorrow at my doctor's office?
Are you asking for you personally? Like, are you protected long term against the measles?
Assuming I had measles as a child, is that a lifetime protection?
So in general, yes, we say that people who have had measles as a child are protected lifelong. They don't need like a booster dose on top of that.
All right. Second question is access to vaccines. So let's assume that the House of Representatives substantially cuts Medicaid. And let's assume that Robert Kennedy doesn't want to put federal funds to give free vaccines to poor families. What's the risk of people can't afford it? What's their route to get vaccinated for their children?
Yeah, I mean, I worry about this a lot. So we're talking specifically about the Vaccines for Children program, which provides much more than measles vaccine, of course. But if you look back to the early 1990s, which is when this when VFC started taking shape, we had measles outbreaks across the country in 89 and 90. There was a huge outbreak in Chicago. It was hundreds and hundreds of cases. There were at least 10 deaths in children. And I think that providing free vaccines for people for whom it's an economic challenge to get vaccinated is crucial. Like, because people won't make that choice on their own, and they shouldn't have to. This is something that, anytime you vaccinate, you're doing two things. You're vaccinating for, for the child who's receiving the vaccine, and to some extent for the collective, like to some extent to provide, a little component of herd immunity. And I think, even if it were just to protect the individual children, we would owe it to them to make those things free. But I think especially because there's community benefit.
So if I didn't have insurance, how much would I have to pay out of pocket to come and get a vaccine for measles? What's the retail cost of that?
I don't actually know the question to that, the answer to that question. I think it is, that's a vaccine that's been around for a long time. I don't think it's one of the particularly expensive ones, but it's something that should be free. But thank you.
Hello. It's not a question, more like an addition to what you were saying. I don't know if it's a coincidence, but in 2018, 2019, there was a measles outbreak in Samoa, in independent state of Samoa, and right before COVID hit. And I think that experience helped them to prepare for then handling the COVID, because they were very quick once there were just few cases of COVID around Pacific, not even in Samoa. So they were very quick to close the country. And also interestingly, that they were one of few countries that reached like 98% of COVID vaccination. And I think they didn't have any active cases until like they already started vaccination. So I think well, in a way, measles was a bad experience, but at the same time, like it did help them to get through COVID, and now they're even more serious about like strengthening their surveillance systems and everything like that.
Yeah, the Samoa measles outbreak was a disaster. There were 83 children who died, and RFK played a role in seeding anti-vaccine sentiment there. But I agree with the idea that sometimes outbreaks can make you more prepared. And I think that on the very small scale of the place that I work, I think that you're right. I think we learned things during that 2018-2019 outbreak that helped us move quickly during COVID.
And that Samoa outbreak, it's been top of mind because in the Robert F. Kennedy confirmation battle, Democrats kept saying this is a preview of what could happen here. Kennedy said I had nothing to do with it. I just happened to be there meeting with these folks. And it was interesting as a reporter in the room, I don't know if this came through on TV, when the Democrats would ask about Samoa, in the first day of hearings, I think Kennedy supporters booed. In the second day of hearings, there was a bunch of us reporters were looking at each other because we all heard someone trying to hum and drown out the question about Samoa. So it was a very sensitive thing for the Kennedy supporters to have this reminder.
Hi, good evening. So I think there are plenty of people in the crowd who are either in or pursuing careers in public health or medicine. How would you recommend to not lose hope in this time? And how would you recommend, going about conversations with those people who, are RFK supporters and are losing trust in the people who have devoted their lives to helping them?
Yeah, it's hard, and we need you. I spend a lot of time with the people in my clinical division and my research group, and people who care deeply about public health and about taking care of kids, and it's a hard time to not lose hope. But I think that there will always be a place for clinical medicine. There will always be a place for public health. These things don't get less important because some people say that they are, and it's a horrible time, and it may get worse, but we need you. Thanks.
So
Dan, you've already outed me. As Dan knows, I spend a lot of time talking to people in the anti-vax movement. I've chronicled the rise of RFK, et cetera. One of the things that they will say is that before the measles vaccine was introduced, only 450 to 500 kids died each year of measles, and now we're 60 years hence. We've got much better medical care, all kinds of things that we could do to keep kids alive. So why is it necessary for the state to mandate vaccination? Doesn't my individual liberty take primacy over, the requirement that all kids be vaccinated? And I'm wondering how you would answer that.
So first of all, thank you for your work. I'm a big fan. Yeah, I mean, I think that that's true. In the last year or two before measles vaccine licensure, we had, call it 500 deaths a year in the United States confirmed due to measles. That's, tens of thousands of hospitalizations, but 500 deaths. Those hospitalizations are bad. Measles induces immune amnesia, which can make kids susceptible to other infections for several years afterwards. So there are potential long-term effects of measles. 1 in every 1,000 to 1 in every 10,000 kids who gets measles develops SSPE, which is subacute sclerosing panencephalitis. It's a chronic neurological disease that is invariably fatal. So there are low probability outcomes that are very important. I would say that 400 to 500 kids, those are real kids. Those are children with families so I would argue that it is worth vaccinating everybody to protect those kids, even if that's the only thing we're talking about. And there are, you can frame it as individual liberty. The problem is that that other reason that we get vaccinated is to protect the people who can't get vaccinated, either because they're not old enough is the most common reason. Like, we only start vaccinating against measles at a year because the vaccine works better at that point. I take care of kids in the hospital who are getting chemotherapy and can't get vaccinated, or who have primary immunodeficiencies and can't get vaccinated. We vaccinate to protect them. I think there are a lot of reasons to do that go beyond just, that number sounds low in the context of the United States.
Was that an acceptable answer to the New York Times?
It was. I'll let someone else ask a question now.
Well, I have a quick follow-up as someone's coming to the mic. So you talked about the folks at risk. Kids get vaccinated, MMR, at about a year, and they get a second shot around 4 years old or so. How vulnerable are kids between that first and second shot?
First dose is somewhere around 93 to 95% effective. Second dose gets you up to about 97. So the vast majority of kids are protected after that first dose. And you can give the second dose as soon as 28 days after the first dose. We don't, because we do it right around the time of starting kindergarten, because that is kind of the first point at which kids really have a vaccine mandate, that they're going to school where there's vaccination mandated, and it's a convenient time to get the vaccines all caught up. But there's no magic to the 4 to 6 year old one.
Thank you.
Well, I've enjoyed your talk immensely. I am a professor of neurology and at a New York medical school, and I have seen with my pediatric colleagues the effects of sclerosing panencephalitis, and that child is just horrible. What I would think is, my idea is, could we, in states that are definitely interested in protecting the lives of children and understand an unvaccinated child is like a loaded gun in the hand of a 6-year-old. And that's what it is. Now, how can we use this idea of mine or other people's to tell the governors in our states where this would be okay to use as a fear campaign, because it is really a terrible thing to understand. My older brother had polio. One arm, one leg worked, sort of. And who was my dad's best friend, who was also a doctor? Albert Sabin.
All right.
And United States was very skeptical about oral polio vaccines. So where did Sabin first try it? Should I tell him?
Someone said it already.
Yeah, Russia.
Soviet Union. Yeah.
It's okay to kill the Russians off, but
Actually, I am his son's predecessor.
what?
Successor. I'm Mikhail Chumakov's son's successor. So Mikhail Chumakov ran the clinical trials in the Soviet Union for OPV.
Oh, wow.
They were regulated or reported by Dorothy Horstman at Yale as having no back. And his son made a test while he was here at the FDA to do molecular consistency, and that's the last paper that Albert Sabin ever communicated to DNA.
Yeah,
My
Sabin
takeaway is
also
that we may need to
developed a type
rotate
of-
the seats up here for
Seriously.
crowd.
And unfortunately, Sabin also developed a type of neuropathy, which a friend of mine took care of when he was at the NINDS. It's a small world.
Doctor, do you have any response to?
Yeah.
No, so thank you for your work. Thank you for your question. I agree about subacute sclerosing panencephalitis. I've only seen a couple of children with that, fortunately, over the course of my career. It's a horrible disease. And I don't know how well the fear messages work. I don't, it's
That's
hard
the
to,
question I want to know.
it is
Do
hard
fear
to know
work?
what will work.
Could it work?
That's going to be hard to follow.
Seriously.
As a humble training pediatrician,
Yay.
hey, I guess what is your advice to us who are training in this new era of vaccine hesitancy? I remember my parents, I grew up in Latin America, my parents being quite fortunate in bringing me to the US to get vaccinated for access. So me having to talk to this vulnerable population, Hispanic families here who might lose access, or, the poorer families who are being targeted, how do you, what is your advice to help them and educate them?
Yeah, I mean, I think that there are two things in that. There's the lack of access, which really needs a policy solution. And I don't know if that ends up being state policy or that ends up being federal policy. But if VFC goes away, there needs to be a policy solution to that. And then there's the other question, which is how do you communicate around vaccine hesitancy? And I mean, we need your help. It's hard, and I will be the first to say that I communicate a lot with parents about vaccines, but I am an infectious disease specialist. I see kids in a hospital. It's usually kids who are hospitalized with a vaccine preventable disease when I'm having that discussion. That is the people who are the superheroes in this are the primary care pediatricians who are having those vaccine conversations, day in, day out, and it is exhausting, but it is important work.
Try.
So I have a couple of questions. So we give a ton of vaccines to children. What happens if we just narrowed it down to the top 8? So you said we're only going to give the top 8. We're going to postpone Hep B and other things, and we just made the top 8 of MMR, polio, DPT, and actually advocated more for hexavalent or pentavalent vaccines, which have been licensed in this country but are underutilized.
So I think it's hard to choose what your top 8 are because, I mean, you do that and you end up with kids with chronic hepatitis B and with liver cancer as a result. They're all important. I agree with you about multivalent vaccines. I think that I was having this discussion with my cousin earlier. I think that there is something to the idea of if we can combine more vaccines into single doses together, if we can move more vaccines to oral or nasal delivery as opposed to shots, maybe that helps in terms of acceptance, but there's not stuff on the vaccine schedule that we shouldn't be vaccinating against. It would never make it there.
I'm not saying not vaccinate. I'm just saying, like, instead of giving Hep B when we do, maybe give it after 2 or 3 years.
Yeah, but perinatal, we don't have to get in the weeds,
Yeah,
but perinatal HSV,
And what
Hep B
happens
is important.
if we introduce, so sometimes vaccine hesitancy has to do with other things in economics. So if we made vaccine hesitancy or vaccine administration part of food security, like, so that no? Because there's a lot of people who have food insecurity, and that's a major concern.
Sorry, are you saying that if
instead of paying for the vaccines or supply or giving vaccines free, but combining it with a food security program?
I mean, you could.
Because you could then talk to the parents and have more people come. Because sometimes you are, at least internationally, you're missing people because this isn't what their largest concern on a daily basis is. Their largest concern is how to feed their children.
Sure.
And so if you combine it with a food security program, then you could reach potentially more people.
Yeah, I think from a practical point of view, a lot of these things are combined. I mean, in the U.S., like at a doctor's visit, you have many things being discussed. I think in a lot of aid programs, they're co-localized. But I agree that there should be that there should be sort of
because we're kind of living in an economic bubble. This isn't like, New York City, Washington, Philadelphia. They're more wealthy than, let's say, rural Missouri or Idaho, where like you're going now 5 to 6 hours to have maternity care because the hospitals have been closed, and you're more dependent upon health clinics.
we're getting near the top of the hour, so if there is, I think maybe one more question.
Okay. Yes, I've just changed my question. I want.
It's also about food and vaccines.
No question, Adam. So as somebody who works in public health, we were always told, how important it is to follow the exact vaccine schedule, because then people don't fall through the cracks. They're sure to get all their vaccines when they're supposed to, and there isn't as much, loss to follow up. But in terms of meeting people where they are and trying to make them comfortable, how do you feel about, changes to the timing in order that it's kind of a follow-up to that question because I know a lot of people are just afraid of getting a lot of vaccines at one time and afraid for their children to do that. So how do you feel today, given where we are?
Yeah, I mean, I think that the way that vaccines are studied is as a component of the schedule. And so what we know about safety and efficacy, we know with the timing of the schedule, like a lot of thought goes into putting the schedule together. And there's no known benefit of delaying any of the vaccines. And there is certainly risk, even if the only risk you're talking about is an extra month, an extra 2 months of susceptibility to whatever the disease is. That said, if that is, if you're a pediatrician and that's the difference between a family vaccinating and a family not vaccinating, sure, then you have that discussion. But I think that most pediatricians will push at first for the regular schedule, A, because it's the thing that is studied and we know about safety, and B, because it's front loaded for a reason. Like it is to provide protection against things that affect young children while the children are still young.
I think we're almost out of time, but as the moderator, I want to use the last moment to ask one last question from the book. You detail the episode in Texarkana, the city that borders Texas and Arkansas, and a measles outbreak that hit the population of Texas in the side of the city and not Arkansas, because Arkansas had vaccine requirements and a campaign. Texas didn't. Is that a preview of what is coming in America?
Absolutely. So that, and we saw this during COVID. So the Texarkana story is in 1970, there was an outbreak. The city straddles 2 states. The 2 states had very different vaccine policies. Even though the population was split between the 2 sides, you saw essentially all of the cases on one side of the state line. not surprising because A, vaccines work, and B, vaccine mandates work. What we saw during COVID was exactly that, where you had states where, redder states where there was more opposition to vaccine mandates and less uptake of vaccines had higher COVID death rates. Like, your political party affiliation was a risk factor for death during COVID. That is lunacy, but it is true. And so, yes, I think it's a Texarkana is a prelude, but we've already started to see that.
And on that note, his name is Adam Ratner. The book is Booster Shots. Dr. Ratner, thank you so much.
Thank you both so much.